Alright, so is this the correct wording? The motion for this round is that LGU healthcare should be re-centralized.
Health services?
Health services should be re-centralized. Okay, let's open the debate with Prime Minister. You're here.
You're here.
You're here.
Ladies and gentlemen, Madam Chair, what really is the problem in status quo? What is really the problem in this debate? The problem is very much simple. It's that the decentralization or the status quo policy on a decentralized system of healthcare appropriation is insufficient, Madam Chair, to address the needs of public healthcare, Madam Chair. Now, why is this the case? It's because in status quo, local government units has complete autonomy in terms of having to dole out funds, Madam Chair. And in terms of that decision making, other things actually come into their mental calculus. Like, for example, the building of roads, them looking good in front of the people, Madam Chair, and all of these other things come into play. However, what happens is that society, as a response, is already used to having subpar healthcare system, Madam Chair. We see people seemingly kind of being people actually kind of okay with having to deal with, a 50-50 chance of having to deliver a baby with high mortality rates, with a very alarming, doctor-to-patient ratio to begin with, Madam Chair. Now that's where policy enters into this debate. Our policy on re-centralization. Now how does our policy occur? Now, our policy is very much simple. It's that the DOH will no longer be just an office that actually regulates the actions of the LGUs in terms of what they do with the funds or the extent of funding, but really would already be able to appropriate the funding to these hospitals, to these public hospitals, to make the decisions on behalf of these local government units. I will substantiate why that has to be the case as I go on with my substantives. First, a few characterizations. The local government units are basically political subdivisions, and they are guaranteed autonomy in terms of local services. But we believe that health services are different. It's something that's intrinsic to a human being. It's intrinsic to the right to life, Madam Chair, of individuals, and that's something that's exclusive to health. But yes, again.
Okay, are the existing problems that you have identified with local government units purely on the basis of the structure of centralization, or are there other factors that contribute to the problem of the local government unit right now?
We concede that there may be other factors, but the biggest factor here is the current status quo of the decentralized form of governance in terms of appropriating funding, and I'll talk to you more on that as I go on with the substantives. But first, why is our policy valid? It's because we believe the principle that a poor person from Makati is no different from a poor person living in far-flung areas in Mindanao or wherever else in the Philippines. The extent of care forwarded will no longer be affected by where you are, what LGU do you have, but rather your health center will be given the appropriate funding from the national collective chunk of the DOH. So what happens is that you no longer care if your LGU is someone who's an addict in repairing roads. We no longer care if your LGU is someone who's actually have other things in mind in terms of funding. When we talk about health, when we talk about anything that pertains to public health, we now go to the DOH, and the DOH will be in complete control of funding, Madam Chair. So I'm going to talk about three things in this debate. First is on how it promotes equality, or how our policy promotes equality, not in terms of automatically having better hospitals, but we leave it to the DOH to handle. Second is how we are more flexible in terms of dealing with health problems. And third would be how is decentralization necessarily forward better health service. So first is on how it promotes equality. Now, what happens is that this is especially the case because DOH specializes obviously in healthcare. The appropriations will be insulated then from the whims from the winds of sudden budget cuts of the local government because the rise and fall of local government income doesn't impact the budget to be allotted by the DOH for the healthcare of its citizens. So what happens, Madam Chair, is that no longer will it be a case whether or not the local taxes will be able to sufficiently fund advances in healthcare on a local level. But really, Madam Chair, what happens is that people being at public healthcare would be insulated from that, and they will be given proper appropriations according to the need of that municipality, of that public hospital, as ascertained by the DOH. Second is on how we afford more flexibility to individuals. Because what happens is that our paradigm best adjusts to sudden outbreaks. For example, like SARS and all of these other things. Because the pool of money can be spent to focus on stopping the outbreak of an epidemic in a particular area or region before it balloons to another region before more damages are being accounted for. It's different from an LGU who would just like to insulate his own city and would not spend for another neighboring city, Madam Chair. It would insulate his or her own interest within a particular city. It does not forward public healthcare as a collective, Madam Chair. Before that, yes.
But isn't it also true that the DOH or the national government has the right to intervene in cases of emergency? And are these powers not sufficient for the national government to be empowered enough?
So, what's different is that when it comes to emergency, we are actually restricted to our own individual interests, Madam Chair. What am I talking about in this? It means that, for example, if I'm someone from Cagayan, and then there's an outbreak somewhere near, for example, in Camiguin, or somewhere far, for example, somewhere in Luzon, what would incentivize me to actually spend money for those people for stopping that outbreak in those areas, especially if there's a lesser chance for me or for that outbreak to reach my city at the end of the day? I would spend for insulating my own citizens, Madam Chair. I would not spend for something like getting or like quarantining the people there or spending for medication for people in that area. That's
Sir, and that's the reason why there's only a threshold by which local governments can have full control. In instances where there's a national outbreak or where there's a national state of calamity, national governments are able to step in and do all the things that you wanted. Why is it not enough?
It's not enough for them because what happens is that it's something that's very much subjective. It doesn't need to escalate to something of a national phenomenon in terms of the gravity of the outbreak for people on the ground to care, Madam Chair. So what happens is that under their paradigm, it's only until it has escalated to epic proportions before these things would actually would matter to the government. And last argument is on how re-centralization forwards better health service. Better health service come when decision making is no longer encumbered by other decisions and priorities. When LGUs decide about health appropriations, they also think about other things like roads, infrastructures, other things. Now, why is health a priority? Funds need to be decided by DOH. Why is it that funds need to be decided by the DOH separately? Because LGUs have different mental calculus, especially in terms of healthcare as a priority, especially when we're dealing with a society that's already being used to subpar health facilities. We need change from the top level management, Madam Chair, because we're dealing with a society that's already used to these subpar facilities. And how do we best change that? It's by better appropriations, more appropriations that are suited to that specific appropriations that are best suited to that area, appropriations that are no longer affected by infrastructure or whatever else that LGU thinks need to be prioritized, but separately as health, because health is something that is intrinsic to the person, intrinsic to their life. That's exactly why we're very proud of the proposal.
Wait, I lost the time.
8:20.
Right. Thanks, PM. Hello.
It is absurd, Madam Chair. It is almost like these local government units were granted autonomy for no reason at all. That they were nothing more than mere puppets who don't know what they're doing. They're just doing whatever they feel because it's fun.
Here.
It's apparently because we have a government that just assumes that when the city prioritizes something over something else, it is because they want to deprive people of the other service manager. It's because these local government units are trusted. And I'm going to talk about that later in my constructive. As leader of opposition, and as in opposition in general, we believe that it is important for us to respect the autonomy of local government units and their decision makings in providing healthcare management. Of course, we're not going to say that the status quo is completely fine. We are very much well aware that not everyone is getting enough healthcare. There are poor people, and we need to make the world a much better place. But these are things that do not necessarily need a re-centralization of the system. As a matter of fact, we think that we can always solve the problem by, for example, improving health information systems manager, allowing local government units to be able to effectively express their needs manager to the higher ups, ladies and gentlemen. Secondly, and we necessarily allow them to have proper allocation of whatever aid manager that might be given coming from the national government, not coming from the national government. The point is, we don't think it's necessary for us to take the LGU and disempower the manager when it comes to the decision makings of this particular kind of service. Let's first directly respond to the things that Albert talked about. Sit down. First, according to him, the problem is status quo that there is an insufficiency of healthcare because there's a matter of priorities. The reason why priorities are done managers because we know that there's a limited resource. If we think that we need to give more money for people for these LGUs to have healthcare, then we allow these LGUs to apply for a bigger budget by substantiating the need manager through statistical research to these individuals. We don't see why the LGU has to allow the government to necessarily assume what they want and what they need. It's a hard that I'm going to discuss later in my constructive. Secondly, we're not talking about instances where the LGU just concedes to the existence of a lot of maternity deaths or where public hospitals just ignore people who cry for help. Obviously, we're going to defend this model under the instance of where there are basic requirements manager that would otherwise constitute as great abuse of discretion on the part of the LGU if they do these things, ladies and gentlemen. Then Albert Kanian talked about the matter of equality because according to him, rural voters have the equal rights with urban citizens manager. Well, this is true. They have equal rights to basic healthcare. They have equal rights to be protected by their own local government unit manager. We'll explain later why this equality is meted out even if they come in different forms, ladies and gentlemen. And then they talked about the problem of epidemic breakups. He had already created a POI and said, obviously, if we have a problem with emergencies, the state can step in and take control because those are instances which you cannot expect us to say is still completely fine. But because I'm very much original, I think that the other response is this, that there's a natural incentive for these local government units to help each other. Because at times when you're the one that has a calamity manager, the other local government units will also want to help you as well. That's exactly why when Sendong struck manager, other local government units that had no reason to help each other still help each other, not just because we're human, but because we knew that later on we're going to be able to receive that help from them later on. But then again, he said, and more importantly, manager, we think that the LGUs would have the greater capacity to be able to identify the start of these epidemics to begin with. The only problem when there are breakups is because there's poor communication system that transfers to the national government, and that's not something that can be done without improvement of the status quo. We believe, manager, that the evolution of healthcare services is a necessary step to successful Philippine governments. When the local government code was created in 1991, it was a unique act of the Republic of the Philippines of effectively governing a very special archipelago, which is our country, where cultures vary, demographics are diverse, and needs situational manager. The purpose of the local government code brought agencies directly responsible for the services of the people within their locality. This is why city governments get to declare their own holidays. They get to enact unique criminal laws and ordinances within its jurisdiction. That's exactly why they get to decide our allocation for security forces, economic investments, and even cultural norms. The LGC is entrusted all of our fundamental human rights to our immediate local government, except of course for the military, because that's a national defense state. So the question is, why is healthcare any different? Albert responded to this by saying that it's intrinsic to individuals. I don't even understand what he meant by that. Because even cases of murder, transactions of marriage, and elections are governed primarily by local laws manager that are enacted through a devolution from the constitution manager that's granted by the national government. I don't see why this intrinsicness is any different from any other kind of fundamental human right any other service out there.
What stops an LGU from misappropriating funding?
I have that in the argument. First, why is it important? Because they are the ones directly responsible for their constituents. Governance manager is more than just an allocation of rights, but an achievement of social satisfaction to the delivery of these multitude of rights manager. Meaning, you don't get satisfaction by just giving healthcare. It's also about economy, creating infrastructure, giving jobs to people. These are things where local governments have to give priority over the other. Firstly, local government units are expected of their own experts of their own demography, and their leaders are chosen based on their expertise. Sometimes healthcare needs to be put in the backseat, but these are safeguarded by minimum requirements through national standards. If you compare this with national governments, they tend to allocate at a top-to-bottom approach, leading funding to possibly to be necessarily wasted. National governments tend to give what's best, while LGUs give what's necessary. This is exactly why when national governments give funding for a calamity situation, there are normally an influx or a surplus of goods that are given to particular areas that have to be transferred elsewhere because they don't even know how much exactly is needed by these governments. More importantly, in principle, LGUs need to be held accountable by their constituency in order to allow such LGUs to satisfy their own people. The mandate of the national government may not always run in consistent manner with what the voting public in that particular city wants. You betray the people manager by forcing the mayor to believe what exactly the president wants you to do. This is where I'm going to talk about our POI. They are less susceptible, Madam Chair, to bad governance. In terms of budget allows them to be, local governments have to apply properly to the national government and tell them statistically why we need that. On the other hand, if you talk about the national government, we have to rely on what the country basically can afford to give us based on their national allocation. Ladies and gentlemen, on the level of corruption manager, it's much easier for a person to complain against a mayor manager rather than you complain against a president who has greater responsibility over other people who would say, I failed to help you because there are other factors that are involved, Madam Chair. But lastly, we think that local autonomy allows them to be able to actualize themselves as a people. Because the LGU services are based on local revenue, which means that they get healthcare based on how well they are able to strive. If you create, Madam Chair, a national budget budget for everyone, you create a dependence between local government units from the revenue of other groups, Madam Chair. And this is against the interest of national development, where you want productivity to go all over the country. Ladies and gentlemen, you encourage people to work hard and develop themselves as a city, Madam Chair, in order for them to be able to give the best services possible. This is the greatest incentive, Madam Chair, that you could have when it comes to ensuring healthcare. Of course, you might be able to hear from government that this is necessarily something that might not work in the short term, but in the long term, Madam Chair, and in terms of the permanence, Madam Chair, of the services that will be provided in the long run, we think that these services are better off when they're in the hands of the people who know them the most.
Thanks, PPF.
Two arguments put forward to government's case manager. First, I will talk about the disadvantages of decentralization that's actually happening in status quo. And secondly, I will talk about what does decentralization do to the state and the society at the end of the day. But before I proceed to my arguments, Madam Chair, first, Madam Chair, is the idea coming from the opposition that this creates more opportunities for LGUs, that decentralization actually creates more opportunities for LGUs to help other LGUs in times of need. Our response to this, Madam Chair, coming from government is very simple. It's not really exclusive. Meaning, this can also happen even if they get disenfranchised of their autonomy or their power health services to the national level, national government, Madam Chair. Then my first argument, what are the disadvantages of decentralization, which is what's happening in the status quo. LGUs right now have the autonomy to decide what their priority is, meaning that they have control over the operationalizing health service to its people. Moreover, the allocation of budget will depend on the income of a certain LGU, which means that if they have high income LGU and if they are a high income LGU and at the same time they have high priority on healthcare, then the budget allocation of the central government and the national government will also be higher. The problem with this, Madam Chair, is that it creates a certain measure, or it introduces a certain measure of inequality. How is this so? We say if another LGU has the same level of healthcare prioritization, but is a low-income LGU, then what does this tell us? They certainly won't be getting the same allocation because they don't contribute much to the total national income anyway. But more than that, we see there's a more intensive disadvantage that poses serious harm to the state and the society, Madam Chair. Now, what this includes is, first, it is more difficult for the central government to monitor the implementation of a program. Why? Because of the autonomy of the LGU to operate on providing health services to its people. Even if we say that LGU is an extension of the central government, what's happening in the status quo is that there is no intensive communication of what every course of action that the LGU take, Madam Chair. What the central government will only be getting is an accomplishment report. We say if local authorities have better access to local information, then those at the national level will be hindered from doing their job because of the limited access to information. And because, Madam Chair, truth be told, we just don't work in such a way where transparency is being highly regarded, which leads me to my second point of disadvantage, Madam Chair. Decentralization encourages local corruption because of the fact that local government knows more what's happening inside their community, which means that the national government only gets what's being given to them, like reports, which we cannot even be sure if true and correct or not given the threat. And given the trend, Madam Chair, we say this encourages local corruption. Local authorities will easily just manipulate things in their report in favor of them just to get bigger budget allocation, just by saying that this is what we need and this is what's happening. And because of, again, the limited access to information of the national government, or the DOH in this case, Madam.
Corruption. It's about whether or not these people do receive the services. That's the most important thing. Why is this the case? Because an example happened in 1992 where 6.5 billion budget of the DOH was distributed to all public hospitals, which went to provinces that did not even have a running hospital, ladies and gentlemen, because they did not have an analysis of what's happening on the ground. The inability to have an acclimatized appreciation on the ground makes it pro for national government to implement projects that are not appropriate to the needs, or worse, invest in curative healthcare services that generally cost more in the long run, but isn't really able to maximize people's optimum health condition. Like for example, generally in the Philippines, Madam Chair, with eradicated cases of tuberculosis and or hepatitis, but there are still certain provinces in the country that has cases of tuberculosis or hepatitis that are very high. What does it tell us? It tells us that in most of these places, we cannot rely on a reactive government program, which will be the case because the government does not have a preview of what's happening on the ground. What's going to happen is, instead of providing preventive measures to provide immunization against tuberculosis or hepatitis that would have prevented the transmission of these things, we would then result to people going to hospitals having their tuberculosis treated as opposed to it having been preempted in the first place. Sit down. What's the conclusion? In terms of promoting an appropriate and nuanced healthcare services, it has to be preventive in orientation, which can only be done through a system that allows a unit that knows the community very well, Madam Chair. But another thing is, the that we have right now is archipelagic in nature. In times of delivering services, time is of the essence. The DOH can't be there at all times, Madam Chair. When a pandemic breaks out, you need to have an immediate response. You cannot expect the national government to do that immediately because it's not omnipresent and omniscient, Madam Chair. That's why you need the LGU to be there as the first line of response. And that's the reason why when it fails, that's the only time the national government comes in after this point. But second, Madam Chair, if the national DOH fails, the entire country fails. Remember when there was an outbreak of meningococcemia, Madam Chair? Let's try to assume that that happened in NCR, where the seat of power is. If that happens, entire country will be paralyzed, even if majority of the people in Visayas and Mindanao are not affected by it, Madam Chair. You're not going to allow these individual services be able to be provided for the people because the entire system is paralyzed and it has fallen apart. Yes.
Rene, local knowledge is not something that's exclusive to local government units because there's also local DOH centers that can actually get those information and forward to the national level.
This is where the second point comes in, Madam Chair. Healthcare is also an exercise of an individual's autonomy. You cannot force an individual to subscribe to any healthcare services, even if it's best for them if they don't want to. The best way for you to deal with them is to encourage them. Because it's not a one-way process. These people have to be receptive of the service provider. And this is where we need someone that they voted into power, someone that they recognize as a legitimate authority, not just someone that you transplanted there. Remember how you determine regional directors, for example. You have one regional director from Region 1, for example, that will be rotated and will be transplanted to Region 12, even if that person did not come from that particular region. Number one, that person does not even have a knowledge of what's going on there. That person has to study first. The person has to know what's going on there before the person becomes effective. But more importantly, will people really believe the mandate of that person? Not necessarily the case. So in terms of, ladies and gentlemen, allowing these people to reciprocate to the services that you're providing, you're never going to have that with their model. And the state recognizes that, and precisely why it devolved the power that it has and allow individuals to have more power. But what did we hear from this side? The only thing that we heard about them is that we are concerned about the squandering of health budget. Number one, it's a false assumption that the national government is immune from every cases of squandering. FYI, not only did we have a Supreme Court justice that was impeached because of that, we had several precedents that have been filed cases of corruption. We have a lot of these cases. But second, there's an assumption that the national government would not force its projects through local institutions or public hospitals. The example that I've given you about the 1992 6.5 billion budget, seniors receive more money than they should have, even if they don't have hospitals to run. Madam Chair, this is another manifestation. But finally, Madam Chair, I don't know if these guys are checking current events, but last time I checked, Madam Chair, there have been several counts of budget misuse that has been identified and was posted in the website of the Department of Budget and Management, COA. All of these things are in there. They're already checking, and that's why, Madam Chair, these people do not just run scot-free. Before I go to my final argument, yes.
Rene, what stops me from believing what stops the people from believing someone who is like a regional director from DOH on matters regarding health? What stops me from believing him?
Because I told you, Albert, that you cannot force people to just subscribe to a particular healthcare service because you are offering it. More often than not, Albert, you have to make people believe that it is important for them, and it has to come from someone that they recognize is concerned of their needs and who knows their needs, Albert, not just someone that you placed in there. Now, going on to the last point, Madam Chair, the quality of interaction of people with their government affects how the individuals view their government. So if we try to look at what we have in the status quo right now, it's not just the health services that's decentralized to local government. We have environmental protection, disaster risk reduction management and climate change adaptation, we have gender development, social welfare. Health being the most basic services that's subscribed to by people, Madam Chair, its failure to be appreciated by people affects how people perceive their local government as a whole, which affects the delivery and appreciation of all the other services. But finally, Madam Chair, if there's already a need for them to act out. For all these reasons, we think that there's a value for us to having this centralized system. It's working right now and it can be better. Thank you.
Alright, thanks. Government with
Here, here.
Here.
It's not fair for Renan to say that health services we have right now is actually good. When in fact, there are proof that statistics shows that that women or people in rural areas have lesser tendency to live compared to the people in urban areas. In fact, it is proven that people in urban areas actually has 10 more years to live compared to the people in rural areas at the end of the day. Given this kind of issue, Madam Speaker, we think that there is an inherent problem that has to be solved at the end of the day. And we think that this kind of problem can be attributed solely to the structure of centralization that we have the centralization that we have as a policy at the end of the day, Madam Speaker. I have two issues in this debate. First is the issue of autonomy, and second is the issue of will health services be better through re-centralization. So first issue about autonomy. RPN has this very good rhetoric that we don't want to be puppets of the national DOH, Madam Speaker. We want to have our own policy. But they also concede, Madam Speaker, that intervention is necessary when there's danger. The question then is, where can we actually draw the line at the end of the day? Is the difference of the lives who get to live more years in NCR isn't an urgent matter for us to solve this kind of problem or address this kind of problem, Madam Speaker? If not, then how come they didn't really draw a line if where urgency is actually or state intervention or national intervention should be necessary at the end of the day, Mr. Speaker? They also said that they have autonomy, like example, how policy are actually being given autonomy to it when it comes to economy and laws or etc. at the end of the day. The answer is simple. We think that these states vary from one province or another. Only the locals can arbitrate their economy or the development in economy because there is no uniform standard that is applicable in developing different regions across the country. An example is that the reason why Bukidnon's law are focused on agricultural development is because they're dependent on agriculture at the end of the day. Just like example, in Surigao, there are also policies are also about content about mining because they're different. The difference in development is different compared to any other. Unlike healthcare, Madam Speaker, their needs are universal or similar across the board or national level. Like example, a laboring woman from NCR has the same needs as a laboring woman in ARMM, Madam Speaker. We cannot deny the fact that the universality of healthcare is present when it comes to healthcare. Before going on, yes.
Okay, if the local government units deny basic healthcare services, don't you think there's enough incentive for the people to warrant them to change their policies?
That is a perfect segue to my second point because I said that it's easier to complain to a mayor compared to complaining to a president. Conceded. But this will only fly under the assumption that the locals are willing to complain. Remember, only a few percentage of the locals know that their municipalities are actually obliged to give them health care at the end of the day. Kian's argument Kian's POI will only fly if the locals are actually concerned with complaining these kinds of issues at the end of the day. Because unlike making healthcare sit down, decentralized, once the more informed people in NCR demands for more healthcare rights, it can also benefit the people who are less informed in ARMM or people who has one voice and etc. at the end of the day. We think on second issue, will health services be better through re-centralization? We said that yes. Because we told you, which they never really clash, Madam Speaker, we told you that local DOH workers are not aliens to that local community. They still come from the community, but the difference from what we want is they didn't have to run for an office to represent the local status in health. Original director doesn't solely decide what's needed by the locals. He only considers the data and gathers from the local people through studies and surveys, because that's what they do. Sit down. So going on to my second, to my issues, Madam Speaker, we have ENPOI earlier. Are the problem caused solely by the principle of decentralization or with the implementation? Sir Speaker, sit down. We said that this problem is caused solely and can be attributed by the structure of decentralization. How? We think that by giving sole autonomy to LGUs will limit the utility for the manifestation of health services. Like first, management capacity. When you allow the LGU to facilitate, you make health services subjective and up to arbitration of the people who are working in the LGU. We think that these kinds of things are limited to the information of these people who are working there at the end of the day, unlike the knowledge of national LGUs, Mr. Speaker. Albert already told you these kinds of things, how national has bigger outlook compared to the limited outlook of municipalities, Madam Speaker. We think that by this kind of policy or decentralization, the ignorance is lessened. They are more aware of the necessary steps to do. And secondly, Madam Speaker, is that we think that the problem of lack of resources. Albert already told you that municipalities has smaller areas compared to big cities or urban cities, Madam Speaker. This is the reason why they cannot afford to buy high-tech facilities unlike Makati or any other high-income earner cities that can actually address their needs at the end of the day. Now, we think that quality of healthcare don't varies then in this kind of scenario. So meaning, for us to be able to provide equality across the board, Madam Speaker, is for us to be able to make sure, Madam Speaker, that the resources that they actually have is equal. Yes.
Why do you expect Makati to have the same era as, I don't know, Cagayan de Oro or illegal, even if they have lesser population, even if it's less urbanized? And why can they not just use the budget that they have to provide for the services that you
Madam
wanted?
Speaker, I'm not expecting Makati to have the same era. What I want, Madam Speaker, is that the quality of service that they got, Madam Speaker, like example, 1,000 patients in Makati should always have the same quality of 1,000 patients in rural areas at the end of the day. So going on, Madam Speaker, we think that Rene said that they have different services that they want. So let's just let them be at the end of the day. Like, we don't think that this is how things should go, Madam Speaker, because just because people from the mountains want to go with the top doctors, Madam Speaker, it doesn't mean that we tolerate them at the end of the day, or what they want, we should always give them. Because rights are there not because of people, we don't take away rights when people don't want to use them. We always make it available for them to make sure that anytime they want to avail of it, they should have it already, Madam Speaker. And we think we have already told you that even if decision making will be decentralized, but the local DOH will still do the surveys and info gathering of the necessary diseases that has to be addressed locally and nationally at the end of the day. Given all these reasons, we think that autonomy should not be absolute, and second, healthcare will always be better when we actually decentralize it.
Thank you, Madam Speaker. The issues for this round will be very clear under my speech. I'll first discuss the question of, is there a need to decentralize? This will be answered by an appropriate question with respect to, should health services really be under the national government's control? The second issue is with respect to the implications of the policy. Are we looking at the removal of local government's autonomy in delivering health services as either a bad thing or on to the first issue, the idea of the need to decentralize. What we were offered by side affirmative was a discussion on the need on the basis of three elements. The first is the lack of proper and equal treatment for patients with respect to different geographical locations. The second is the idea of the inability of the current mechanism to respond to crisis. And lastly is assertion of better appropriation under a more centralized model. Let's deal with this one by one. Firstly, the concept of equality. First of all, are the dispensements of the services right now unequal? According to affirmative side, it is on the simple aesthetic instance that the same kind of service that you get on one area is not the same kind of service that you get on another area. First of all, this kind of action is not a reflection of inequality, but rather a reflection on a diversity of prioritization that exists in different municipalities and in different local government units. It doesn't mean that universal health care is regarded less within these areas. Because if that were the case, then the national mandate, the constitutional mandate towards your right to have proper health is obviously something that's attacked even by the local government itself. The only autonomy comes with respect to prioritizing certain health projects over others. And we agree, sometimes it must be important for us to render, for example, proper prenatal care. But in many instances in provinces wherein the resource is finite, we need to be able to appropriate it to what they need on the ground, which isn't going to be prenatal health care in all instances. It might be immunization, it might be other elements that we think their kind of budget will be able to procure. That's why inequality doesn't exist even on our side. But more importantly, this kind of characterization is unresponsive to the model that we offered from side opposition. The idea that we're not fine with the status quo right now, that yes, we do need to improve, we need to reform the system, but the reformation of the system comes in improving the structures that support the system, not changing the structure in itself. If we like decentralization, we like the idea that local government units are able to arbitrate the basis of need based on their constituents, not on the basis of a very vague national mandate that they are so confident of. But more importantly, the conclusion towards this issue of inequality is simply this. We think that we are not dispensing in equal service, but we are dispensing equitable service, appropriate to the budget, given that community in itself. This is not only a fiscally sound policy, but also a fiscally efficient policy. That was the substance that came out from the Deputy Leader of Opposition. The idea that before the decentralization, you had a lot of national programs that dispensed money even in areas where they didn't need money that much. We think that's the kind of garb that we avoid. Moving on, this idea of the flexibility after this, the flexibility to respond to crisis. First of all, the perception of the inability of the local government to respond to a crisis is on this vague assertion that most of the time local government units insulate the problem. First of all, we're very curious insofar as, is the insulation of the problem really a harm? Because we don't think it's a harm. In fact, when the local government exhausts all its power to be able to contain the problem within the region, we think it's a good thing because that's a standard operating procedure in being able to prevent a spillover on other various provinces. We don't think that's a particular harm. But more importantly, in cases where the national emergency comes into place and there's a greater national interest, there are existing administrative powers provided by the state to be able to intervene. But the only difference is simply this. The threshold of intervention is on the burden of proof of the national government to prove that the local government is unable to deliver the services that are needed. That's the kind of check and balance that we think is fine within the system, as opposed to a system where we simply delegate the power of the local government to the national government without any kind of litmus or incentive to prove whether or not the local government was clearly failing. At the end, the conclusion of this rebuttal is simply this. Under their side, they presume that the local government fails at all times, which we think is not only harmful on the level of principle, but also harmful on the level of practice, with respect to looking at how these local governments came to be. The idea that they were voted into power, the idea that the constituents expected them to deliver not only in terms of various services, but a complete service. And that's where better appropriation also comes into play. The idea that when we construct, for example, national projects, like for example roads, it's as if it doesn't have any kind of relation to the completeness of health within a barangay. The assertion of side affirmative out of this issue is that when we prioritize roads, we are immediately deprioritizing health. first of all, at face value, we don't think this is hard. Because when we provide for roads, we also provide for people to be able to walk in these roads and get to hospitals that we think are unable to be delivered, if not for this kind of priority. In many instances, we think that people would rather prioritize their job security over health in general. Because in many instances, having the capacity to pay, for example, for a hospital is as much a cure as for example, a very vague national mandate with respect to cure in general. The conclusion to this issue is simply this. When we take away the autonomy of the local government, what you necessarily do is that you impair the completeness of the service that the local government is able to dispense. And the point is simple. We need to be able to retain the integrity of the local government unit because that's the only way for them to be appreciated in the status quo right now. But more importantly, for people to see and feel that they voted people in power not only because you had expectations for various services, but you had an expectation for complete service. In many instances, the ability of the local government to provide for health goes hand in hand with their ability to provide for security, their ability to provide for economic opportunity. We think that's the completeness that we're willing to defend on our side. Yes.
If it's about contribution, will you then define that there are 10 more people who die in rural areas because, sorry, your poor and rich cities don't want to help you?
And that's why under our model, we require local government units to be
Is
more...
going to save people like them. The so-called things that was discussed in this debate, according to them, it is the only ground why they wanted to propose what they proposed is healthcare is intrinsic to individuals. I completely agree. But if that's what they wanted, why are they disempowering people on the ground from holding their direct authorities accountable? Why are they, Madam Chair, appointing someone who these people are less likely to believe? If you think that these rights are so intrinsic upon every individual, why do you enact a policy that empowers the government more than its own people, Madam Chair, leading them to so much dissatisfaction? The second question is, where do we draw the line? Or did we draw the line? We did, insofar as opposition is concerned. We told you that national emergencies are done through interventions on a case-to-case basis. The question is, where did they draw the line, Madam Chair? Because I dread the day that we would rashly declare states of emergency simply because the people of this barangay don't live as long as the next barangay, Madam Chair. And even then, if they say that this is a form of emergency, we think that emergencies are responded to by drastic measures, not permanent overhauls of our government, Madam Chair. The question was, if the situations and the circumstances were normal, are you still going to re-centralize the government of the healthcare system of our government? Next question. Are we depriving people of rights? No, because we told you that LGUs are needed to be able to determine whether these people need these rights or else you will end up giving an excess of these rights, which results to a deprivation of other rights which would have been less prioritized. Even DLO, Madam Chair, explained to you that the government has no right to shove condoms down the throats of people who don't want them or whatever other kinds of rights that you would want because of their beliefs. We told you that governance is about societal satisfaction. It's not just about healthcare, ladies and gentlemen. There was a standard which I gave you in my speech which they never responded or even cared, Madam Chair, to meet with their policy in the first place. How does prioritizing healthcare to an absolute degree puts them at a level where you satisfy your constituents on the ground? Because rights are not ends in themselves. So what then, Madam Chair, is our future if we allow this policy on the part of government? We will come up with a society where we think that health is the only right that matters. Well, LGUs, at the risk of them being re-centralized, will have to put rights all the time. Even, Madam Chair, if we think that there are other needs that need to be placed there, because obviously maternity deaths are automatically the fault of everyone everyone in the local government units. It doesn't matter if we're all jobless, Madam Chair. It doesn't matter if we're all crawling on gravel, Madam Chair. It doesn't matter if we don't really get to go to school. That as long as we're all healthy, as long as there are no maternity deaths, Madam Chair. In that kind of situation, we are not going to be okay.
Healthy na ba yung maglinis ka sa grama? Boba?
Thanks. Go. Reply.
Madam Chair, of people are completely okay with high mortality rates, alarming doctor to patient ratio. This is not a matter of customary differences. This is not a matter where I can say that people from Samar are actually used to subpar healthcare centers and people from Makati are used to high-end health centers. This is not a subject of local variation, Madam Chair. What the government has consistently forwarded in this debate is that it's not something of a customary difference that is different from region to region, from city to city. Because we believe that healthcare has universal roots. What is important to an individual from Samar is similar to a person living in Cagayan, similar to a person living in Makati. And all significant arguments by the opposition side pertain to issues that had a lot of mutual exclusivity. Things like local knowledge, corruption, all of these other things both exist either way you look into things. Because national government units also have local branches, like the DOH having a local branch, them also having local knowledge. But what is the difference that we're trying to forward at the end of the day? Is that there's a presence of change from the top level management, Madam Chair. That given a country that already considers subpar health centers as already part of their lifestyle, and so the LGU that is also used to this, will also, forward the same appropriations. That's where we need to change things across the board. That's why we need change from the top. That's why we need change from the national government involving the people as a collective. That's why we take this debate. Thank you.